I know we kind of went through introductions last time, but if you're new here, maybe you're wondering, what does Kate do? Well, she's a licensed psychologist and serves as the director of research and outcomes at OCD Anxiety Centers. She received her doctoral training in clinical psychology at American University, and she developed specialties in the treatment of anxiety disorders, obsessive compulsive and related disorders, and body-focused repetitive behaviors. Dr. Rogers has worked with OCD Anxiety Centers since 2016, holding direct clinical training and quality assurance compliance roles. As Director of Research and Outcomes, she collects and analyzes data to improve clinical outcomes and collaborates with universities and researchers across the country to help close the gap between science and practice. So this is part two of our two-part CE. Today we're covering part two of OCD and anxiety, what community providers need to know. Kate, we're going to turn the time over to you to find out a little bit more.
Thank you so much, Joseph. I really appreciate how many people once again showed up for this. I'm so excited in the interest that we're getting from the community. I even see a couple of familiar faces in here. So hi, if I already know you, it's good to see you. Um, Last time we did part one. Hopefully you were here for part one. If you weren't, hopefully you were able to review the recording that Joseph so kindly sent out to everyone. Really quick recap. Last our heroes met, we walked through really the first of our learning objectives, which is to gain that understanding of the nature of OCD and anxiety disorders. And we walked through some really specific hallmark features to look for when screening for these sorts of diagnoses. And really the goal, the overarching goal of these sorts of CEU events is to help empower community providers to get better at screening for these disorders, appropriately flagging and diagnosing these disorders, and feeling really empowered to support their clients through recovery, whether that's entirely within their own services or if it involves referrals and collaborations with additional community providers. I think one of the best things that we can do for these populations is work together more and better. So I really encourage you as we go through this, like look around the room. There's a lot of people here today. See if there's anybody that stands out that you really want to connect with, or you feel like, wow, this person could really help me get my clients what they need even better. It's so valuable to rely on each other more and more in our community. So we talked last time about how anxiety is just like an alarm clock. We've got our anxiety alarm. And what we really zeroed in on last time was the importance of recognizing do, 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 that people with OCD or an anxiety disorder have one thing in common. That alarm is busted. It has become a false alarm, going off when it doesn't need to, screaming a crystal clear message of danger. The same alarm that goes off if there's a grizzly bear in front of you. This alarm goes off in our clients when they are not in danger. We talked a little bit about the different disorders where we know there is a false alarm at the core. We walked through some of those hallmark features to help us kind of go beyond just the DSM criteria that can just be like a lot of text. Honestly, it's just a little less helpful in the moment sitting with a human being client. We walk through this list of hallmark features just to help us better screen for and flag these disorders that have that false alarm at the core. We spent a little bit of time talking about what do we do about it and using exposure and response prevention for these diagnoses. We, whoops, wrong way. No, we haven't gotten that far. All right. Spoiler alert, spoiler alert. We're going to talk more about using exposure and response prevention anytime there is a false alarm at the core. Now, Before we jump into that, as we're talking about assessment and screening, just appropriately flagging these clients, one of the things that I always like to scream from the rooftops is please make sure to screen for suicidality. Oftentimes in our field, we think a lot, talk a lot about suicide risk when we're working with other populations. We're really good at doing this with major depressive disorder, right? It's like our go-to thing. We're really thoughtful about it. We're not as good at consistently screening for suicide risk when it comes to our clients with anxiety and OCD. Those clients whose alarm is going off when it doesn't need to. These clients are just as vulnerable to suicide risk and suicidality. So it's really important that we're thoughtful about this every single time. One of the things that we do in our clinics, and I will happily share these questions with all of you and encourage you to use them every single day. For every single client, we ask 3 safety questions. And remember, our clients, we're an IOP. Our clients are with us 3 hours a day, 5 days a week. Every single client is asked these safety questions every single day. And the safety questions are really thoughtful. They are number 1, are you having any safety concerns? I really love this nice broad safety net that we throw out there. Um, because it allows for the sorts of things that you might not think to ask about, right? Are you having any safety concerns? This opens up the floor for any discussion about abuse, a discussion about homelessness. This really broadly opens up the floor to any and all safety concerns. It is really, really helpful catch-all. And then we get more and more zoomed in as the safety questions keep going. After we ask, do you have any safety concerns? We also ask, are you having thoughts of harming yourself or others? This allows us to start zooming in on suicidality, but also helps us catch any homicidality that's coming up. I'll say we certainly see much, much less of that in our clinics with the populations that we treat, but we have caught it. It has come up. And if we hadn't been asking these questions really explicitly, really consistently, we wouldn't have caught it. And that would have been a very different situation. We also always, always ask the point blank question, are you suicidal? We aren't prettying this up. We're being really clear. We're normalizing this language, immediately showing our clients this is a safe place to talk about these things. This is safe language. We're going to take it seriously. We're not going to panic. Using this language in these 3 questions has been so immensely helpful at our clinics. Are you having any safety concerns? Are you having thoughts of harming yourself or others? Are you suicidal? If we get a yes to any of these questions, then we can meet one-on-one with that client, do things like the Columbia Suicide Severity Screening. Big shout out to the Columbia Lighthouse Project. That is such a fabulous resource. I strongly encourage everybody check it out if you're not familiar with it. This offers free resources, including the Columbia screening tools, as well as online training resources that are really pretty good. If you have a clinic with multiple providers, this is what we use to help support and train providers very quickly to make sure everyone's doing this the same way and doing it well. I've got a link to it right here in the slides, which Joseph also has. Now, I could spend like 3 hours on this topic, so I'm going to touch on it really briefly. The other thing to be aware of when you're screening, assessing for these sorts of diagnoses is something called PANS or PANDAS. Show of hands, anybody already know what this is? Is anybody familiar with PANS or PANDAS? If you're not, This is going to be really disappointing because you think of pandas and it's like a super cute bear. This is not the super cute bear. For me, that was really disappointing. PANDAS stands for, this is just an excessive acronym, Pediatric Autoimmune Neuropsychiatric Disorder Associated with Strep. You can see why we shorten it to PANDAS, because that's awfully long. Now, PANS is just the same basic thing, but not specific to strep. It's a little bit more broad. This can be things like COVID, Lyme disease. Those are two that I've certainly seen. And the essence here is someone with pandas has had a very abrupt, severe onset of OCD symptoms. And I'm talking like overnight. I've heard this described as a strike of lightning. Kid goes to bed, totally fine. Wakes up a different person. And the reason is because their brain is inflamed. There's inflammation in the brain because there are certain things, unfortunately, that can cross that really cool blood-brain barrier that we all learned about. I thought that was the coolest thing when I learned about that in science back in the day. It turns out I'm like really disillusioned by it. It's not quite as powerful as I had thought it was. And there are plenty of things out there that can just scurry right across that blood-brain barrier. For example, strep. Strep cares not for the blood-brain barrier, just scurries right on by. And because it can, we end up going into the brain, kind of wrecking up the place, and creating inflammation. And inflammation in the brain can cause acute, abrupt OCD symptoms. This is really scary for families that experience this. It's incredibly jarring. This is the sort of thing that can bring a family to their knees. It's exhausting, it's scary, it is all encompassing of their lives. So, why does this matter to us? This is a medical condition, right? And we are not medical providers here. We're mental health providers for the most part. This is still very, very important because if you are in a position to be the one to flag this, you can make a massive difference based on how quickly you can flag this. If we can identify these symptoms and get someone to an appropriate medical provider within the window of active infection, then a medical intervention like high dose, longer term antibiotics can get full remission of symptoms in that client. As a field, we're super bad at that. We are not great at noticing these things. We're not great for screening, not great at screening for it, or even knowing the resources to send someone to. So I always like to put this here. Here are the things that I want you to look out for. First thing is sudden abrupt onset of severe OCD symptoms. In someone that already has OCD, this might look like all of a sudden you like poured gasoline on a fire and those symptoms just exploded overnight. Or it can happen in someone that's never had any OCD symptoms whatsoever. So that's the first thing you're looking for. Like a strike of lightning, all of a sudden we have severe OCD. Along with that, you're looking for that to have a buddy. And that buddy might be sudden onset of sensory dysregulation, suddenly being really sensitive to light, sound, taste, textures. Taste is often a really common one. If both of these are happening at once, go ahead and raise the flag and get this person to an appropriate provider. And we'll talk a little bit about what those providers look like and how to get to them. If the sudden onset of OCD symptoms comes with a buddy, there is a sudden onset of eating restrictions. That is a really big red flag. That is one of the most common combinations that we see, and it's really scary. You've got a little kid, this is a pediatric thing, right? You've got a little kid that has stopped eating. Like, I don't know about you, but I have like a 40-pound 8-year-old, and that would be really bad really fast. So this can be especially scary and genuinely dangerous. So we want to be really, really good at flagging it when it happens. The sudden onset of OCD symptoms may also come with a more surprising buddy, bedwetting. This can happen in an older kiddo that has not wet the bed in a very long time, and all of a sudden we're seeing this bedwetting happen again. This might also just look like a kiddo that feels like they have to pee all the time. That is really, really commonly seen in our PANS and PANDAS cases. You can also see a sudden onset of tics, vocal tics, motor tics in a kid that has never had tics before. Um, and the last one is genuinely hard to catch, um, but it can be helpful. The last one is motor abnormalities. In a medical setting, there are a lot of really interesting screenings that they do for this, but in mental health, it's really hard to catch a noticeable increase in clumsiness in a pediatric population. If you've ever spent time with children, they are inherently somewhat hilariously clumsy. I have watched my son run full force, face first, into one of those big windows at like the ninja gym for like the part, just like it just bounced off like a bird. And that's like a normal day in a typical child. So it's really hard to spot clumsiness. I've seen a kid get stuck in a chair. Like it wasn't pandas, it was just, they were just 10. And that their body is changing and they're trying to navigate it. So, the key to noticing motor abnormalities in this population in a mental health setting for me has always been handwriting. I have caught 2 cases in my career because their handwriting changed overnight. Like I said, we're in IOP. I see these kids write on the whiteboard every day. There were 2 kids throughout my entire career. I was like, that's not your handwriting. So I called a meeting with the parents and I screened for some medical stuff, and it was clear as day. Uh-oh, this is a kid that already had OCD. Gasoline on the fire, handwriting changed overnight, and we were able to catch it during active infection. That window is not super long, so you want to be really vigilant about this. And the best thing we can do is start by just being knowledgeable about what you're looking for and what it might mean. If you get this first one, sudden onset of OCD symptoms, severe, abrupt OCD symptoms, and any of these other things, raise the flag and get them to a medical professional to screen for PANS or PANDAS. Now, this can be very tricky because then what? Like, where do you send them? I highly recommend Dr. David Voss in Utah. That is our go-to referral for PANS and PANDAS, that we will send people straight to Dr. Voss, and he's really great about getting people in quickly, and he takes pretty good care of them. This is like what he does all day, every day. This is his jam. And so we're really fortunate to have that resource. And some clients are completely unwilling to do that. Some clients and their families are really attached to their own pediatrician for any number of reasons. And in some other areas, not near Dr. Voss's clinic. Utah's a very big place. And we have clinics outside of Utah. There's often a shortage of specialists, medical providers who are specialists in this area. There's also a lot of controversy in the field, and people be arguing about language and getting into some serious nerd fights about this. So, I highly recommend a resource called the Pandas Physicians Network. I promise you there's a link in this slideshow that'll take you right there so you don't have to bother writing it down. I've got the link in here. But the Pandas Physicians Network is a really helpful online resource that actually provides not just some general information about PANS and PANDAS, but provides the specific diagnostic and treatment flow charts. So I have printed those out and had the family of the client take it with them to their pediatrician's office and go through it together. Plenty of pediatricians have been amazingly responsive to this. The more we can collaborate and work together, the better off these kiddos are. Does anyone have initial questions about this before I move on? We'll spend just a little time on it.
Yeah, Kate, it sounds like a couple people have dropped questions in the chat, just kind of basically asking, is this something restricted just to children or youth, or can it also manifest like in older teens, or maybe there was another question, does it also manifest like in an adult who maybe suffered, from strep a lot as a child?
Yes, yes to all, actually, which is a very confusing statement, right? Because those seem, you know, counter to each other. That is such an important question. So I'm going to answer it in a few ways. Number one, pans and pandas, as is the specific research and the fluff, is specific to a pediatric population. Not because the same phenomenon can't or doesn't happen in a non-pediatric population, but because that happens to be the population that we've studied. And so I think that is important to be thoughtful about, recognizing that this is not in any way exclusive to children, but the name Pans and Pandas and all of the research attached to it and all the treatment guidelines attached to it is specific to children because it has only been studied in children. So we have to be really thoughtful about that. Now, the other piece of this is pediatric here refers to anybody until 18, which is like so stupid, right? But again, that's just how how the populations fell in the research. Um, so older adolescents are considered in the same grouping here. And great point, whoever that was in the chat. Absolutely, we do see adults who, when we get information about onset and course of illness, we're like, wow, this was probably pandas 20 years ago when no one was going to help you with that. And so, something to be aware of is the natural course of pans or pandas when it's not full remission during that active window of infection is a course that is remitting and relapsing, meaning you get flares. Similar to like rheumatoid arthritis, right? There's flare-ups of inflammation at times, triggered by a number of environmental factors. Um, for pans and pandas, we see the same course over time. Someone might be doing amazing in treatment, and all of a sudden, their symptoms just seem to explode for no particular reason. But they might have the sniffles. So someone with pans and pandas, when they get reinfected with something, tend to experience a flare. Their brain experiences inflammation again for, a more temporary time period. It tends to be pretty transient, but also pretty dramatic. This can be somebody, again, that's been doing so well in treatment and making beautiful progress, and all of a sudden they seem to relapse really hard. Um, what doctors often use in these scenarios is just things to control inflammation as best as possible. I'm talking like Motrin, antihistamines, these sorts of things. Steroids I've seen used. There's a lot of options there, but it's really just kind of a band-aid for the moment. Because once we are in adulthood and we missed that period of active infection, we're going to likely have that relapsing, remitting course over time. Did I answer all three layers of that one?
I think you did very well. There was one question also. I'm not exactly sure, but I think they're asking like, did the pandemic cause pans? That was the question. Or it's I mean it's caused by the strep infection itself, right? So it's probably something that's existed for a long time.
So pandas has existed for a really long time. It's been researched for a good while as well. Um, pandas is specific to strep. and long predated the pandemic. Pans also long predated the pandemic. We've seen it often with Lyme disease is personally the route that I've seen the most cases with pans. Lyme disease has really been some of the roughest PANS cases I've ever seen. Um, and I remember when the pandemic hit, right? We were already like the go-to specialists for pans and pandas in the community. And I remember starting to learn about COVID. And I remember sitting all of our staff down. We just had the two clinics at the time. I sat all the staff down and I said, brace yourselves. I've got a bad feeling that we are going to see a massive wave of pans. Now, initially, for honestly like 2 years, we didn't. And I like took a nice breath out. I was like, whew, I love being wrong right now. I love being wrong about this. But a couple years after the pandemic hit, we did start seeing some cases trickle in where the pans had pretty clearly been caused by COVID. There's some limited research on this specifically out there. There's a good chunk of research on encephalitis related to COVID, which is the overlap here. But there's some specific, mostly case studies that have been published around PANS related to COVID since the pandemic. So it certainly wasn't the wave that I was afraid of, but it does exist, and we have certainly seen it in our clinics.
Someone else asked if it was restricted to OCD, or can it also affect things like depression or ADHD?
Oh my gosh, that's such a great question. Pans and pandas is specific to OCD symptoms. However, inflammation in the brain can cause a lot of different symptoms. Long COVID has been very much linked to an impact on mood and depressive symptoms. Um, so I think any inflammation in the brain can wreak havoc in a lot of different areas. We've seen onset of psychotic symptoms as a result of this inflammation. But PANS and PANDAS, again, as it's been researched and kind of grouped together, is specifically looking at that population that's having the OCD symptoms.
And Kate, someone who's exhibiting, the symptoms of this, do you treat them for strep? Do you treat them for OCD? Or how does like a provider go about treating someone with PANS or
The
PANDAS?
answer is yes. So this is where the collaboration among community providers is so critically important. The mental health clinician is going to treat OCD just like you would treat OCD in anybody else. And it's important to do that with some general understanding of PANS and PANDAS, with some additional family support. Again, the family is exhausted. It's important to create a space where we are listening to the family. Parents have often had to relentlessly advocate for their kid to get help and be listened to. So making sure that as the mental health providers, we're really capturing those pieces and maybe adjusting some of our expectations around those likely flare-ups and being thoughtful in our relapse prevention plans about how we're going to navigate and manage those going forward in a way that sets our clients up for success. Um, and we're going to work directly with the medical professionals. A nice multidisciplinary treatment team is highly, highly recommended. Please, please talk to each other and to the client. And the medical provider is going to handle the antibiotics or additional more invasive measures as needed based on the treatment guidelines and flow charts. Um, and sometimes we'll also bring in a dietitian or a nutritionist for those kiddos that have had the onset of restrictive eating. I've had a PANS client with a feeding tube. So there's a big range of what these cases can look like. So you want to be really, really thoughtful about who is on that multidisciplinary team and how you're being actively collaborative with each other and with the family.
Someone else asked if an autoimmune disease, for example, lupus, in an adult, can that cause a flare in OCD spikes in clients?
Yeah, there is some evidence to support that. I don't think it's been tremendously researched at this point. I think it's an area where I'd love to see more research come out, but there are some cases that's talked about that very thing for sure. Really, and anything linked to inflammation, right? And there's so many things linked to inflammation, rheumatoid arthritis, same thing. We've seen some cases come up like this. And they just get medically tricky. And anytime somebody is medically tricky in your care, you want to be thoughtful about that. Come at it from a very trauma-informed care lens and all work together. And
Yeah, here's,
I'll
oh,
move us
sorry.
forward after we've got one more, and then I'll move us forward so we make sure to get to the rest.
Fantastic. Just one more. It looks like Noelle is saying that she noticed several symptoms of pandas in their teen and mentioned it to a pediatrician. They ran a strep test and said it was negative and ruled out pandas. So, if it can be caused by things other than strep, so for example, COVID, she says, I'm guessing a simple strep test is not an effective method to rule out pandas.
So the general guidelines, and again, like use the flow charts. They're really, really helpful. The general guidelines is you always start with a strep test. I love watching Sue Sweeto is one of our top experts in pandas. She's at NIH in Maryland. And I love watching her speak on pandas because when she describes giving a strep test, she's like, that kid better be puking. Like it needs to be a really thorough swab. There's also blood tests that are recommended looking for really specific titers that are typically used because it's really, really easy to get a false negative with the classic throat swab strep test. So I recommend those flowcharts and those treatment guidelines. They're really, really helpful. Okay, like I said, we could spend so much time on pans and pandas. I think it's such an interesting thing, and it's an area of the field where we're still learning so much. And so the more we can work together on this, the better we'll all be. But I want to move us to the rest of our presentation today, including when you are screening. I always say, when I was in grad school, I was in a research lab, and so we would do the entire ATIS and the entire SKID, and we would pay people to come in and sit there while we did this very thorough, structured interview. In practice, in real life, like nobody does that. No, nobody has time to do that. It's excessive. Um, and so we have to be more efficient with our screenings and our clinical interviews. One of the things I found to be very, very helpful to keep me from missing things is this little trifecta. If I have any indication that there may be OCD, I'm always also going to screen for ADHD and tics. And if there's any indication that there's tics, I'm also going to screen for OCD and ADHD. If there's ADHD, I'm going to see, you get the deal, right? This has been so, so helpful for me because the comorbidity between these things is incredibly high. And there's just often I call it like a neurologic profile where we often see these things together. Other things that often do come up, but not quite as perfectly as my little trifecta. Autism spectrum disorder, we see really high comorbidities between that and OCD, and it can be really tricky to distinguish sometimes. We also see sensory processing disorder come up often with these cases. So these are the things that I just tend to try to screen for to be most efficient while still capturing all of the important things. Evidence-based care for OCD and anxiety. All right, people have really big feelings about this. And there's a lot of debate in the field about what counts as evidence-based care. So there's an important difference between evidence-based care and empirically supported treatment with like increasingly rigid and stringent guidelines. We're just going to talk about evidence-based care today. The gold standard in evidence-based care for OCD and anxiety disorders is cognitive behavioral therapy, but specifically highlighting the intervention of exposure and response prevention. This is really important. And pause for just a moment. I can't tell you how often I hear people say, I treat OCD, I do CBT. It's important to remember that CBT, cognitive behavioral therapy, is not an intervention. It is an overarching umbrella term, an overarching approach and theory. All CBT actually means is that we believe that thoughts, emotions, and behaviors are linked. If I poke one, the others will move. That is the essence of CBT, cognitive behavioral therapy. That is the underlying belief, the theory behind it. So if you say you do CBT, my goodness, that could mean just so many things. And some of those things are going to backfire terribly if you try to apply them to OCD. ERP is one intervention, one evidence-based intervention within the realm of CBT. Other interventions, progressive muscle relaxation, cognitive restructuring, behavioral activation, all of these are specific interventions that fall within the umbrella of CBT. Please don't do things like progressive muscle relaxation and cognitive restructuring with OCD. Those are going to backfire on you. So you want to be really thoughtful, not just about the overarching approach, the buzzword of CBT that insurance companies love to hear, but be really thoughtful about the specific interventions that you're applying. And what I find most helpful is paying attention to what the cycle of that specific diagnosis looks like, right? What is maintaining this person's suffering? And making sure to identify specific interventions that address those things. So for OCD, it's the false alarm cycle. It's really pretty straightforward. So the best thing to do for OCD is exposure and response prevention, because that is going to recalibrate that false alarm. So let's go ahead and look back at our alarm diagram and take a moment to define some of these things. We remember our alarm, right? We've got the trigger, and then our brain says, oh, danger, it perceives a threat. Our sympathetic nervous system turns on, dumping chemicals into our body like adrenaline and cortisol, creating the feels. We feel the urge to do something to neutralize that perceived threat. And so we do. And every time we do a neutralizing behavior, we learn that threat must be real. That connection there is really strong and really important. Exposure means intentionally placing yourself into a situation where you may be vulnerable to that perceived threat. So exposure is facing this fear on purpose so that I can see, is it a threat? But if I do that, I'm going to face my fear and expose myself to this trigger that I know typically makes my alarm go off. And then you know what? The alarm's probably going to go off. Then we're going to feel the feels and we're going to feel the urge and we're going to do the thing and that we didn't make any progress. We just went around the cycle as usual, strengthening it again. Which is why the second half of this, response prevention, is so important. Response prevention means staying vulnerable to that perceived threat by resisting the urge to engage in neutralizing behaviors. Then, if I expose to the trigger, the alarm goes off, I feel the feels, I feel the urge, but I resist engaging in the neutralizing behaviors. That is where the magic happens because now I'm actually testing my theory and I now have the real opportunity to learn something new about this perceived threat and ideally to learn that it is safe. So both exposure and response prevention are critical elements, and these work together to essentially recalibrate the false alarm so that it's just our typical anxiety alarm. It's still going to go off for the grizzly bear, but it's not going to go off for the teddy bear anymore. ERP, exposure, and response prevention. This is the gold standard intervention that directly addresses and recalibrates that false alarm that's at the core of these diagnoses. Now, I'm a big fan of ERP. Like obviously, I'm the poster child for ERP. It's like the closest thing I'm ever going to get to Hogwarts because it feels like magic. So, all of that being said, as we learn about ERP, sometimes it feels so empowering that we want to use it all the time. And that's where it is very important to check yourself. ERP is not the answer to everything. It's absolutely not. It is a very, very powerful tool and can be used for evil. And that's a big no-no for me. So, the kind of way to check yourself and keep yourself in line with ERP is that you should always be able to map out clearly your client's false alarm. If you can't clearly identify someone's false alarm, ERP is not appropriate. And it's really easy to want to use it because it's so cool. It is only appropriate to recalibrate a false alarm. It should not be used to try to desensitize someone to something they don't like. Big no-no. Only to recalibrate a false alarm. You should be able to identify someone's false alarm, and that's what indicates that ERP is going to be a good option for them. And because this can get really tricky and it's just so easy to mess it up, it's really often important to have a specialist, an exposure specialist navigating ERP with a client. Um, I I have a bunch of checklists in here because I like sharing these slides with people. I think these sorts of checklists are helpful both for providers and for clients to recognize when is the line? Like when should we be getting help from a specialist? If anxiety is getting worse instead of better, and this is honestly the one that I highlight with community providers, we can often take some of these things and kind of dabble in them, but if the anxiety is getting worse instead of better, call it. Get them to a specialist. That is the first most helpful indication that that's going to be the way to go. Don't don't drag your feet on it. Don't continue to torture yourself and the client. Work with a specialist. Um, Also just certain ADLs that I think can be red flags, especially in kids. If they're not going to school, there's a timer on that, right? There's a developmental timer. It's really important that we're not dragging our feet and we're getting someone to the exact treatment they need as quickly as possible. And this is where I say, let's please, please work together as community providers. I think it's so helpful to know like who are our specialists? How do we get clients to you? Um, OCD Anxiety Centers is, of course, always happy to take clients. We are also limited in terms of level of care. We do not offer weekly outpatient as a level of care. We start at intensive outpatient. So we are here for you for any client that needs that. We are always here for you. We don't have a wait list. We take insurance. Hooray. And we have worked hard to share what we know with community providers. We have trained our staff in-house and sent them out into the world as private practice. There are options out there, and it's really helpful to know who they are and get your clients there as quickly as possible and use these as indications of when that needs to be. It'd be really hard to do that. I am a big, big fan of empowering clients. So I love to hand out these questions. Anyone can check the box on the insurance form that says, I'm a specialist in OCD. I'm a specialist in anxiety. And no one will ever ask you any more questions about that. The insurance company's like, cool, done, check. And that makes it really, really hard for clients and their families to navigate resources in the community. So these are some really helpful questions to ask if you are looking for a specialist. If your clients are looking for a specialist, these are the questions I found most helpful. Are you familiar with exposure therapy? Remember, be really cautious if anybody's like, I do CBT, but can't tell you anything more. That's probably not the right fit. Um, Asking what specific training someone has received in the treatment of OCD and anxiety. And if they can't answer that question, probably not a great sign. Asking how much of their practice currently involves OCD and anxiety. This is something where you get better with practice. And so the higher percent of someone's practice that's focused on this, probably the better option that they are. It doesn't have to be their whole practice, but I usually shoot for more than 25%. Do you feel you've been effective in your treatment of OCD and anxiety? I love this one because anything other than the most enthusiastic yes is a big red flag. ERP works. It works beautifully. And so if you've got any, it's like, I haven't really had a lot of success, but like I've had some success, walk away. If you're doing it really well, you've had a lot of success. It works really well when it's done correctly. And I love this last one. Do you include families in treatment? Look for a yes. And if you're a provider in here that isn't enthusiastically saying yes, please consider starting to say yes and being really intentional about including families in this treatment. It makes a massive difference. Levels of care. And again, you guys will have access to all of these slides. You're welcome to them, print them out, take them to session, use them however you like. I found this really helpful as well. I mentioned we only offer intensive outpatient level of care. And I think learning how to navigate the levels of care is really important. I'm a little bitter because I was never taught to do this in my many, many years of graduate school. I'm genuinely still kind of bitter about that. Because it's so helpful and it's often misunderstood. People often think it all comes down to severity in terms of what is the appropriate level of care, but it doesn't. It comes down to how can you set your client up for success? What do they need? If you're looking at levels of care, don't just find out how many hours they're there each day. What happens during those hours is going to be so much more helpful in deciding what level of care your client needs. Things to look for, symptom severity is of course important, but is certainly not the most important indicator. Look at impact on daily living. Like I said, if you've got a kid not going to school, you're on a timer. If you've got someone not eating, you're on a timer. And the best option is to get somebody to that higher level of care quickly, simply because then they get better faster. And look closely at the specific client needs. Do they need that structured family involvement? Do they need medical support? Do they need just someone to hold their hand and walk through the fire with them? That often makes a massive difference. If you've got a client in weekly outpatient and every week they come back and say, I didn't do my homework again, please consider a higher level of care. Because if you find the right fit, then that higher level of care is essentially doing their homework with them every single day. And that will get them better so much faster. and look at their treatment history. Don't keep setting them up to do the same thing over and over again, even if they have mild symptoms. Someone with mild symptoms is still suffering, and why would we set them up to fail over and over again? I always say the worst thing that we could ever teach someone is that treatment doesn't work. Get someone to the right fit as quickly as possible, whatever that is. I've got some helpful resources here with direct links. We've got some specific YouTube videos from the International OCD Foundation specific to supporting families. I think this is often a resource that can be really limited in the community, and the more we can do to connect our clients with these helpful sorts of videos, it can make a really big difference really quickly. I've got information on OCD anxiety centers. We spread like locust, so I give up on keeping this list updated. We're all over the country at this point, and we're always happy to help, not just for referrals. Like I said, we're more than happy to take on your clients when it's appropriate, but we're also here to be a community resource. We are happy to do trainings. We are happy to bring someone, a provider, into our clinics and see how we're doing things, and just give that experience. And we're happy to consult. If you're just stuck on a case and you're like, I don't know what this client needs, please call us. We really are happy to help and just be that resource for people. Those resources are really limited out there, and we're trying desperately to change that and just make a difference. So we're here to help with whatever you need. I also have the direct link for the Pandas Physicians Network that has all of the flow charts on screening and diagnosis and treatment. I also have for you some concrete do's and don'ts. Regardless of whether or not you're an exposure specialist, I think these are just really helpful for any community provider that may be supporting someone through recovery in any way of OCD or an anxiety disorder. So the first thing that comes up, I think, is interesting because it's one that we're all generally good at, right? Like I think at this point in the field, like we try to not invalidate our clients. Or at least we think we're trying to not invalidate our clients, right? As human beings, we're terrible at this. As therapists, we're pretty decent at this. Um, Here's what I mean when I say invalidation. Invalidation is essentially trying to explain to someone why they don't need to feel the way they feel. So, like, think about that for a moment. Let's just all be honest with ourselves. When was the last time you had someone try to explain to you why you don't need to feel the way you feel? How did that go? Good? Did you love it? Was it helpful? Did you want to just punch them right in the face? Totally. So, probably not the way to go. You didn't enjoy it. Now, I want you to think about the last time that you tried to explain to someone why they didn't need to feel the way that they feel. We do it so often and so easily. So, I really encourage us to notice this, be very thoughtful, actively and intentionally use validation. I've got lots of examples here of what this might sound like, especially in cases of OCD and anxiety. OCD especially doesn't make sense much of the time. We've got someone having a grizzly bear reaction to a teddy bear. And so our gut instinct is to explain to them that this is a teddy bear and why they should be able to trust that this is a teddy bear. That is not how this alarm works. Stop trying to convince them. Instead, practice validation. I hear that you're feeling like this right now. Is that right? It sounds like here's what you're most upset about. I understand this is really hard for you. And then be able to take that and turn it into something productive. I can see how hard this is for you right now. I'm here for you. How can I help you do an exposure? How can I help you do something differently to learn something new? Starting with that validation is so powerful, and it's just so different than what our human nature is. So it's important to be really intentional about it. Reassurance is like a plague with OCD, and I see people either fall into it completely or become so afraid that they might give any reassurance by accident that they become really weird and kind of jerks. And now when their client's like, I'm afraid I'm gonna die, they look at them and go, you know what, maybe you will die. I'm like, wow, that was a really weird thing you just did. Like that was really socially uncomfortable. It doesn't have to be like that. Instead, notice the alarm going off for your client. I see how hard this is for you. I see the alarm going off. Teach your clients that language so you can use it together. I see the alarm going off. I know that's scary. How can I help you do an exposure? We've got some nice cheat sheets here. I'm a big fan of cheat sheets. And similarly, how encouragement and accommodation can look different. Family accommodation is especially tricky and so incredibly common. I really highly recommend something that's free to the public called the Family Accommodation Scale. This is so helpful. Type it into Google, the family accommodation scale. I love this scale. You give it to a family member, and it really captures what accommodation outside of treatment is looking like, so you can collaboratively address it together. And I know we're out of time, so the very last thing I'm going to say today is when you start shifting these things, these dynamics with your clients, when a family starts shifting these dynamics with a loved one, it is not uncommon to see extinction bursts. Extinction bursts can look like a tantrum, right? They can be really jarring, really upsetting. It's really easy to take them personally. And I like to remind us it's important to set clear boundaries, and extinctions bursts happen. We are all human and we have all experienced these as fully grown adults that are professionals. Because we have used a vending machine. Everybody's used a vending machine. You put your money in, you push the buttons, boop, 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 pick your snacky. Snacky comes out, hooray. Great, that's the deal we have with the vending machine, yeah? And we've also all had the experience that you put the money in, push the buttons, beep, boop, beep, boop, and the snack does this. And then it like dangles there, taunting you. And what did you do, fully grown adults that are professionals? Yes, you did. Yes, thank you for owning that and being honest with yourselves. You attacked a vending machine, fully grown adult professionals. We all did. That is the essence of an extinction burst. That vending machine broke the deal. It changed the deal on us. It made us very angry. So angry that as fully grown professional adults, we attacked a vending machine. That's all an extinction burst is. And when we can remember that, we can navigate that so much more smoothly and from a place of empathy and understanding with our clients. That's you and me. I know we're out of time. We've gone over a few minutes. I'm so sorry about that. Please use us as a resource. Shoot an email to the email listed here, and we are happy to help you with any of these things. Joseph.
Wanted to kind of scroll back among the chat, and I noticed that someone had asked earlier about Lyme disease. I can't remember if we covered this one or not, but if someone had untreated Lyme as a kid causing PANS, what does that look like as an adult, like with them still having the Lyme disease?
Probably that same flare-ups. It's just really likely to experience those sorts of flare-ups. Lyme disease, especially, I think, is something with often ongoing medical support. And so, again, needing to collaborate with the medical providers, the behavioral health treatment is going to be the same, but with some adjustments in terms of relapse prevention, predictable flares, um, and thinking about how we're going to navigate those when they inevitably come up.
Got it. Stan had asked, are all symptoms or any set of the symptoms necessary for diagnosis of pandas or pans or a single symptom? Like, are you looking for single or are you looking for all of those comprehensively?
Neither. You're just a single is not going to be really enough. Um, but you don't need all of them. I'd say if you've got buddies, if you've got two of those at the same time, that's enough to raise the flag and get them to the next step. And that's going to be the medical tests.
Got it. And then Shelby had asked, is there a screening tool for ticks? Like, are you just doing an in-the-moment assessment or are you looking specifically for ticks?
Honestly, there are a lot of screening tools out there for ticks. Plenty of them are in the public domain and really accessible and through the magic of the internet. However, to be honest, I don't use them. I literally just look at somebody and I say, any history of tics, vocal tics, motor tics, and they can usually answer my question. That's usually plenty. If you're specifically treating tics, I think there's some really helpful measures that you can use to track progress over time. Um, but in terms of just screening and diagnosis, I just ask.
Eric had asked, what are your thoughts on Schwartz's 4 Rs?
Sports is 4 Rs. We have too
I'm not
many
familiar.
acronyms in our field. I need a little bit more.
Eric, do you want to jump in and just kind of clarify a little bit about those 4 Rs if you're still on?
Yeah, it's from the book Brain Lock by Dr. Schwartz. I believe he's in LA. So it's
Oh, yes.
oh my gosh, I'm trying to remember it. Um,
Oh no, I know what you're
you
talking
know what I'm
about.
talking about? Okay.
Brain Lock. Okay, this is so funny actually. Brain Lock is an old book. And this pocket of the field tends to move quickly. And that's great, right? Like there's some really passionate people in this field and we're pushing as hard as we can to evolve the science here as quickly as possible. Um, Brain Lock is really, really outdated. It is a highly cognitive approach to something that we've found is much more responsive to a heavier behavioral approach. Um, it is a very popular book. You know, I was just in a meeting yesterday with someone about how people in our field are typically really bad marketers. Like we're just not great at it. That's why we like completely depend on people like Joseph who do this so beautifully. Because it's not usually our jam. We're terrible at marketing things, which is why we name things exposure and response prevention and prolonged exposure. And like nobody wants to do that. That sounds horrible. And so brain lock was one of these things that really opened the floodgates in many ways, in many positive ways, because it was marketed so beautifully and became very, very popular. But also because of that, and because as a field we haven't gotten better at this, it kind of still reigns supreme in the general public, but has fallen way, way behind the most up-to-date research and approaches. So we don't use brain lock. We don't recommend using brain lock. We recommend using more of the updated approaches. But I'm honestly like kind of eternally grateful to brain lock for getting this out more as a conversation in the general public.
Corey had asked if you would mind describing some neutralizing behaviors again, like maybe even things not to do.
So here's the key with neutralizing behaviors. Remember our definition of neutralizing behaviors is any behavior that tries to neutralize a perceived threat. So it's important to remember that one, every time we engage in a neutralizing behavior, we confirm that the threat is real. Super efficient learning. And that's not always a bad thing. So neutralizing behaviors aren't necessarily bad. That grizzly bear is going to eat your face. Please neutralize. And I really find that so helpful because without that concept, we end up looking for like these cookie cutter neutralizing behaviors that are bad and we shouldn't do. But it is different for every person in every scenario. For one person, behavior X in this scenario is great. That bear is going to eat your face. But behavior X in this scenario is not great because you're strengthening a false alarm. So rather than looking at like, these are the bad behaviors to resist, I find it really helpful to empower providers and clients with these definitions. A neutralizing behavior is any behavior that tries to neutralize a perceived threat. If that's happening as part of a false alarm, stop it. And then we can apply that to lots of different things. It's also important to remember that neutralizing behaviors can be overt or covert. These can be really obvious over external behaviors like washing hands, checking things, asking for reassurance, doing things over and over again. But they can also be incredibly covert mental neutralizing behaviors, like reviewing a scenario over and over again, trying to figure it out and find this special magical certainty that doesn't exist. It can be repeating something over and over again in your head that has this like special magical power to cancel out something else scary. It is truly limitless what a neutralizing behavior can be, which is why just that definition is the most helpful guide. Any behavior that tries to neutralize a perceived threat. Anytime we engage in one, we always learn the same thing: danger. So it was like kind of a cheap answer to the question that was actually asked, but that's what I'm going to give you.
Great. And Steph had asked, well, she made a comment, I'm a neurofeedback therapist and I've seen some success with neuro. What are your thoughts on neurofeedback for OCD?
That's a really great question. I think neurofeedback is like one of the coolest things out there, honestly. Like that again, like closest thing you can get to Hogwarts. Like that is it feels like magic. And there's in terms of evidence-based treatment, neurofeedback is not an evidence-based treatment for OCD. We just don't have the research to support that this is recalibrating that false alarm, which doesn't mean necessarily that it doesn't work. It means we don't have the research to support it. So I would lean towards that because we do have options that have extremely strong research support. I've chosen to hitch my wagon to those because we can help more people with them. I think there's a lot of trying to reinvent the wheel. I think there's a lot of misunderstanding out there, some misrepresentation of some common statistics that say, I heard just the other day someone said, well, ERP only works for 70% of people. That's not an accurate statement. ERP works the vast majority of the time, way, way beyond that number. And ERP only works if you do it. So being providers that can guide someone through effectively, being providers that can get someone to that treatment effectively, being providers that can recognize when someone's pretending to do treatment. They're showing up every day, but they're not doing the treatment. They're doing what they decided the treatment was. That's not the same as the way we're talking about failed treatment. So I've hitched my wagon to helping this be done more consistently, being done well, and being accessible to more people because there's so much great support for it. There are limitless possibilities for what else might work, but the research isn't there yet.
Kate, how are we doing on time? Do you have time to answer any more questions? I'm just going to keep going until you let me know that you've got something else coming up.
I think I'm good. I can answer some more questions. I
Okay,
just got a message that says somebody's covering for me.
fantastic.
We have a lovely team.
Well, and these are fascinating questions. For example, Carolee is asking about some of the safety screening questions that you mentioned at the beginning of the presentation. She's saying, is there a better way to screen for safety issues when a client is obsessive about SI and HI? She's worked with patients that can ruminate on if they might kill themselves or hurt someone else, and asking about the safety screening questions every day might set off rumination about it to where they can't stop obsessing about that question.
Oh my gosh, that's such a great question. Thank you, thank you, thank you. First of all, gosh, yes. Just all the time, right? Like we're an OCD and anxiety clinic. We ask these questions every day. So every day we see this come up because an incredibly common fear in OCD specifically is someone that is terrified that they're going to kill themselves. It is shockingly common. And so, yeah, they're having thoughts of suicide, intrusive thoughts. So we still ask the questions. We use this as a couple of things, some general psychoeducation around language. But those people we still want to pay attention to. We don't want to skip a safety screening there. Um, and someone can be suicidal while simultaneously terrified of killing themselves. And it's important to help guide them through that. And we do it in a really brief and structured way. We're not going to engage in the compulsions. Um, when people say rumination, I think everybody means something different when they say rumination. It's like one of those words where we all mean something different when we say it. So I'm going to shift it to mental compulsions and reassurance seeking, looking for this special magical certainty to try to neutralize the perceived threat that they're going to kill themselves. And again, only when it's a false alarm. So we teach that to our clients. We also, if they say yes, we're going to do the Columbia screening. It is a short and sweet screening. It's very structured, and we teach our clients that we're not going to stray away from it. We're going to do this screening, but we're not going to engage in the broader conversation as it becomes compulsive and neutralizing. And for our clients, that often takes some time for them to get used to, which is why we have a bunch of staff that support us in this. Um, and we often meet with clients every single day to do this brief screening until they start getting a handle on it. This can also be a great opportunity to do intentionally face that trigger and then sit with that uncertainty for the client. And so there's kind of a built-in exposure there when the client's ready to embrace that.
And Elizabeth had asked, what training for ERP do you recommend?
So there's some wonderful training resources, and we're working so hard as a field to make them more accessible. So here's a couple of options that I would recommend. We are providing a 4-hour continuing education workshop in April. I think it's April 24th. It's called Ethically Navigating ERP. It's a very like interactive in-person workshop it'll be down in Utah County. Um, that's a great option to kind of dive into the next layer. The other one that's even deeper and is a fabulous, fabulous training is hosted by the International OCD Foundation called the Behavior Therapy Training Institute, the BTTI, it's lovingly referred to as. It's a fabulous training, zero complaints about the training. Um, it is like getting Taylor Swift tickets. So it's a little bit pricey. I think it's like $750 to register, not including like the travel to get there. And there's often a waiting list of a year. So if you're interested in that, I highly recommend looking into it. It really is an amazing training. But like get yourself on the wait list right now and then consider coming to our training in April as kind of a next step because the BTTI is just takes a while.
Great. Lynn had asked what do you think about the space, I think that's an acronym,
Mhm, yeah,
SPACE, space treatment for parents?
love it. Absolutely love it. It's so space is it's an intervention direct for like younger kids often, but can be applied and has been well researched in older children as well, where the treatment is actually focused on the parents. So you're providing the parents with education and tools around how to navigate this to essentially help the parent become the coach to coach the kid through anxiety. It's a really great treatment. It's got fabulous support. Um, and it really fills an important need in the field of that family involvement, that structured family involvement and really successful treatment. Space is a fabulous option. I love it.
Great. Let's see. Cody, it looks like you have your hand raised. Did you have a question?
Yeah, actually, Kate, you answered. I have two questions. You answered one with the BTTI. I was kind of curious if that's something I should do in the future because I know it is quite expensive and time intensive. I've thought about doing it, but you give it a thumbs up. So,
Yes.
um, is there benefits to getting trained in that? Does that put you on a provider roster? It gives you more exposure
It's some to be honest, I haven't found a tremendous amount of impact from being like in their directory. Like Google has served us better than
Fair
being on the IOCDF directory. However, what I really love about the BTTI is that you will become a better exposure therapist. You will, because what it offers is supervision and consultation. It's built in. It's not just
enough.
like a presentation or a workshop. There's ongoing, you're part of a specific cohort learning this together, and it includes these consultation calls with an expert in the field for like months. And
Okay.
so it really helps support you in applying this to your clients and consulting on those cases. I highly recommend that. That's the model we use in-house in our own training institute, which is actually what someone's covering for me right now is my consultation hour for our own in-house BTTI
Okay.
essentially.
And the other question, thank you for that. The other question is really quick on the pandas and pans.
Mm.
I think I have come across some adult clients now that I'm reflecting on it that it literally could have been that, where it was really quick on set and really, really bad. So, like, I've got one client right now that I'm thinking of that it might have arisen around when they had Lyme's disease many years ago. When I see them, should I recommend that they get connected with the medical realm, even if it's not occurring now? You said there are flare-ups.
I still think there is value in having a medical provider kind of on the case ongoing to
Mhm.
help navigate those flares. Like we just as behavioral health providers, like I can't even technically recommend medication. So having someone on the medical side to even be like, hey, let's try these steroids. Let's take some Motrin. Like I can't even say that to my clients. Um so even if there's not like the heavy hitter medical interventions that can still apply because it's so far after the
Yeah.
infection, I still do think it's very beneficial to have a medical provider on the team.
It's kind of crazy how you mentioned all that stuff because I'm reflecting back towards when I was a young kid. I think that might have happened to me and nobody
Yeah.
caught it.
Honestly, and this is like the essence of our entire careers, right?
Yeah.
Well, and especially as we go to these sorts of CEUs and we learn new things and science keeps on sciencing, we will always look back and think, man, did I screw that up?
Yeah.
I'll tell you, that has been the trajectory of my entire career, and I've finally reached the place where I recognize that's never going to change. As
Totally.
I get better, I will continue to look back and go, man, did I screw that up?
And I used to suck at ADHD. Now I've realized I have ADHD and now I'm good at screening for it. So thank you, Kate.
It looks like there was also a question Lynn was asking about the title of the local Utah County training in April. We're looking for a link to that.
I don't know if it's up yet. We honestly like just barely confirmed the date. It's called Ethically Navigating ERP on our website. I don't know. It probably hasn't even been updated if that's where you're looking. I'd probably look like next week, and
Okay,
I imagine it'll definitely be updated by then and ready to take registrations.
great. And Keegan had a question. Is ERP applied differently or not at all for anxiety rather than OCD?
ERP is absolutely applied at anything that has a false alarm at the core. And we know that anxiety disorders also have a false alarm at the core. And so we're going to use exposure and response prevention to recalibrate that false alarm. There just may be some additional interventions that we throw in to address additional layers of that diagnosis. But the false alarm's at the core, so ERP should be a factor to recalibrate that.
And Charlotte is asking, how would you apply exposure to predominantly mental compulsions?
The same way we do for everything, honestly. I have found it really helpful to give clients something a little bit more tangible in terms of responding. So we talk about the idea of non-engagement responses. So because you can't just tell somebody like don't. Sometimes you got to tell them what to do. And so my favorite thing to do is zoom in on what are they trying to accomplish. That's my favorite question. When we're talking about a mental neutralizing behavior, I ask the client, when you do this, what are you trying to accomplish? Are you trying to prevent something bad from happening? Are you trying to find absolute certainty? Are you trying to cancel something out? And based on that answer, that tells me what kind of non-engagement response is going to be helpful. For example, when I'm trying to find the special magical certainty, I pull from Marsha Linehan's DBT concept of radical acceptance. And we talk about radical acceptance of the painful, blunt reality that there is no certainty. That special magical certainty that OCD demands that you find doesn't exist. It doesn't exist for you. It doesn't exist for me. It simply doesn't exist. And so some people actually I'll give them a little index card and I'll have them write on it, I can't know for sure. And that will help them kind of pull out of that mental loop. And so they learn when I'm trying to accomplish finding that special magical certainty, I pull out the card and I practice that radical acceptance skill of I can't know for sure. And when someone really radically accepts and leans into I can't know for sure, they usually stop the compulsion because they're screwed. What are they looking for? Something they can't have. And so it lets them be kind of released from that loop. I love index cards as my answer to everything. Like I literally had one in reach.
Kate, thank you so much for taking the time to cover these questions or for being so thorough with your presentation. I think it's completely fascinating, the topic that we're discussing. And I feel like we're walking away with a lot more tools now than what we did when we started.
I hope so. That was my hope going in. I appreciate everybody sticking it out, especially when you don't get your extra half a CEO. Um, and I love the comment about, just an extra hour to answer questions. And if there's ever an opportunity to do just like an open Q&A panel, I sign me up. You guys have such fabulous questions. I'd love some dedicated time to just answer those.
Great. Well, thank you again, Kate, and thank you to everyone that joined us today. I appreciate you taking the time out of your lunch and even a little more because we're almost a half hour over. But thank you so much for the time that you've given us. We hope to see you again soon.
Thank you all.